our YouTube channel. There you're going to be able to have all of these webinars. And we want to thank again Dr. Silverman to allow us to record and to broadcast live on YouTube and to keep this recording on our YouTube channel so you can check this session again. We are full of things for all of you during this month of March. Please take a look on our social media. Everything is there. And I'm going to type all the links on our chat box later on so you all can join. Tomorrow we are going to have a very interesting session. Is Dr. Volkan. He is an EP doctor, pediatric EP doctor, who works with me at Sidra Medicine in Qatar. He analyzes a lot of ECG readings and Holter readings, and he discusses a lot of cardiac diseases based on the ECG. It's very interesting, very interactive. So please join us tomorrow. On Thursday, we are going to have an amazing session, as usual, from Dr. Gil Vernovsky. He is going to talk about transposition of great arteries, this transitional circulation, and the immediate post-op care. So please join us. And on Friday, as usual, we have Dr. Anderson's session, and we have this session with some anatomical pieces, samples of Dr. Diane Spicer. It's been a very interesting session. We have a lot of panelists to discuss the session in the end. So please join us on every Friday as well. On the 22nd, we are going to have Dr. Mary Cohen with her ECHO series. She's going to talk about imaging after single ventricle surgery. I'm sure this is going to be very interesting. And on the 25th, we are going to have another meeting of the fetal cardiology series. This is going to be a very practical a session. We are going to talk about things that everybody should know about fetal cardiology, not only fetal cardiologists. So please join us and please share with your team. And today we are happy to have Dr. Silverman with us. He's continued his session that he started in February this year with transposition. Today, he's going to talk about anomalous pulmonary venous connection. And we are very happy to have him with us today. And if you want to see more than what he's doing, please go to MD1 Word. He is publishing an online book. You can buy chapter by chapter. I bought a lot of chapters already because it's very interesting. You have everything that he's going to show us today and much more there and on his online book. So thank you very much, Dr. Silverman, to be with us today. I'm sure this is going to be an amazing session. And thank you guys for joining us today.
Share the screen. Okay. Okay. So thank you very much for having me today. I'm going to be discussing this work, which is largely based on work in my chapter on the echomorphological correlations in congenital heart disease. And today we're going to be doing anomalies of the pulmonary veins. Can you all see my screen, Grace? Is this okay?
Yes, all good.
Okay, good. All right. So totally anomalous pulmonary venous return is the first item. And these are divided into veins that drain above the heart, to the heart, and below the heart. And we'll first talk about pulmonary vein return with veins draining above the heart. Here are some diagrams. This is from Dr. Netter's book, which shows the examples of the three structures above the heart with a vein draining up into the innominate or brachiocephalic vein and then down to the superior vena cava. There are veins that drain below the heart. Here, there's the diagram of the pattern of the veins draining into the inferior vena cava, and veins that drain to the coronary sinus, which are an example of veins that drain in the heart. And on the right are these various varieties above the heart, a nice diagrammatic scheme, to the heart, to the coronary sinus, and below the heart. And what I like to call the fourth type, which is when the veins are mixed, where some drain above the heart and some drain to the heart.
We cannot see the second slide. Sorry for this time.
Yeah, it's not moving.
It's not supposed to move.
Ah, okay.
So you are still in the first slide because people is asking about the second slide. Sorry.
Okay, are we okay now?
We see only the first slide.
Oh, you want to go backwards? Have you seen that slide?
No, not yet.
Oh, it says share.
Yeah, we see the first one. Try to stop sharing, then share again.
Okay,
Sometimes
stop
it
the
happens.
share.
Yeah, now share again.
Hit escape, and then let's share the screen.
Yes.
And we want to see this one, right? How are we now?
Now we are not on the first. We are on the second one.
Yeah.
Okay.
Okay, that's the first slide, right?
Yes. Yes.
Okay.
Go to
well, I'll
play.
begin again.
Try to move forward. Yes.
Okay. So this work that I'm doing is also accompanied by Professor Robert Anderson and Diane Spicer and Dr. Philip Purcell and Elena Kipps, who have helped me with all the various graphics that are involved here. So we've talked about this. I've talked about total veins that type 1, which is above the heart. And here are some diagrams. Can you see this all now?
No.
You can't see that?
No, go directly to the second.
Where do I go?
No.
Okay, I'll stop share.
Yes, go directly to the second slide before sharing.
You mean this one here?
We can't see. We're not sharing yet.
And now I share the screen. Let's see where I share the screen. Here, let me just close this. Share the screen. And this is,
okay.
You can see that?
Yes.
And that?
Yes.
Yes.
Bravo. Okay, and now I'm going to put this on full screen.
Okay, try to move forward. Let's see if it's going to work. Yes, very good.
Okay.
Perfect. Yes.
All right. Well, I'm not going to give you a long embryology, but you know, the veins coalesce from splanchnic mesoderm. And as Professor Anderson has shown you, that this drains to the back of the atrium, and this from the primary heart field, and then the anastomosis, which can occur in various directions as part of the venous drainage. And what the story will be here will be the following. We'll be showing you morphology, which is on the left side of the screen. There will be an echo plane to show how the echo cut is done and augmented with a diagram in the middle. And then on the right will be the echocardiogram that will be resolved from this scan plane. This is a sagittal scan plane, so front and back. So, and we'll label these things. So the first thing that will happen, I won't mention this again before, is that the scan plane will disappear off the image. And then you will be able to see the vertical vein as it ascends from the heart into the brachiocephalic vein, and then into the superior caval vein and into the right atrium. Here we see the pulmonary arteries and the right ventricle as it is shown here. The labels will disappear, and then you will see the echocardiogram with the first feature that is important with supracardiac veins is that the vein, the innominate vein, is usually much larger than the ascending aorta because it's assuming a much larger volume of blood flow than just the systemic output. This is the pulmonary flow in the vein, so it's much larger, and it's situated just in front of the brachiocephalic artery. And here you see the arch of the aorta and the right pulmonary artery in the crux. And lastly, because many of you will be looking at this presentation on your smartphones, we have zoomed in this connection so that the veins are all large and occupy, the images are all large and occupy the entire selection. So here the vein is collapsed, obviously, because there's no flow post-mortem, but here in the live situation, we see the large pulmonary vein. Now here is another example, this one obtained from a subcostal coronal image. Here is the subcostal coronal image, and you see here is the confluence of the veins draining into this vertical vein, which is draining in this instance behind the innominate vein and then into the, here you see it here, into the superior cava and into the right atrium here, reflected by the right atrial appendage. And here is the echocardiogram. And this is a very useful technique for looking for veins, because veins that are when the patient is alive after birth, there is a right to left atrial shunt, and a small amount of saline contrast injection here will show the right to left atrial shunt. And this actually is the systemic output, or almost the systemic output of what you see. And you can see that all of the chambers of the heart fill with saline contrast, and you can see where the saline contrast is coming into the heart through the foramen ovale. The patient is alive after birth. Now we're looking at an important section which shows the position of the brachiocephalic vein into the from the vertical vein into the brachiocephalic. And you see here behind that is the pulmonary trunk. And it's very important where the veins drain, because if they drain behind the pulmonary artery and in front of the bronchus, they create the so-called hemodynamic vice, which causes obstruction. And as 60% of all of the veins that we see are of this type, with the type 1 vertical vein, the vein may be blocked. And although obstructed veins are invariable when the veins drain below the diaphragm, the commonest finding of obstructed pulmonary veins occurs in this situation where the vein drains behind the pulmonary artery, between the pulmonary artery and the bronchus. And when this happens, there you can see acceleration in this vein, which is a cause of obstruction of that pulmonary vein. Now, it's not easy often to get this because the vein is running in different directions. It is coming posteriorly, then runs anteriorly, and then runs posteriorly again. So it's quite difficult to get this picture, and it does require a certain degree of manipulation of the probe from the subcostal coronal cut. And here is just a diagram showing this example of obstruction. Here's an X-ray which shows pulmonary edema. Here is a cartoon showing the position of this vein below the pulmonary artery and in front of the left bronchus. And here from Professor Anderson's book, we see this example of the hemodynamic vice as you see it here. And you will see when you look at this low velocity flow in the veins and then acceleration beyond what is probable from the fact that the angle of incination is different. So this is what is called the hemodynamic vice. And of course, that's a very important problem. Now here we've got this picture where we've shown the pulmonary arteries removed. And you can see on this beautiful example, which has been given to me from the Mayo Clinic, that you see the veins, all of them accounted for here, draining into this vertical vein and in front of the pulmonary artery, so without any degree of obstruction within that vein. And here, there's only a small increase in the velocity of flow on 55 centimeters per second. And this is really related to the vein flow. Now, what you see with the color, the color scan is almost a three-dimensional scan, because in the azimuthal direction, the scan is thicker than the two-dimensional plane. And so what you can see here are the pulmonary veins, 4 of them at least, draining from below. The velocity is low. Then there's a small acceleration as the angle of insonation changes. And you can see here the right pulmonary artery over here. The left pulmonary artery is out of the plane here, and the ascending aorta in the middle of that particular suprasternal notch picture. So this is known as the so-called crab view, because it looks very much like a crab, and I think is a very nice example of what happens when you look at the anomalous pulmonary venous return. Now here again is the hemodynamic vise shown morphologically. Here's the pulmonary trunk continues to the left pulmonary artery, and here's the bronchus behind the heart coming from the trachea behind that. And you can see how the artery is sandwiched between the pulmonary artery and the left bronchus. And of course, at this point in time, there's going to be a degree of change in velocity. And here on the echo, you'll see the same feature as we're looking at the vertical vein and the brachiocephalic vein, with the origin of the left subclavian vein coming in there. And you see here the acceleration that occurs at the point of this obstruction. And when you do a Doppler, instead of seeing normal pulmonary venous blood flow velocity, you see high velocity flow. That's 2 meters per second, 1.5 meters continuous flow, indicating the site of the obstruction here. So you can accelerate this velocity. I think I have another slide that shows a pullback from the low velocity through to this high velocity where the obstruction is occurring. And here is such a pullback where the obstruction is. Here's the pulmonary, left pulmonary artery and the bronchus behind, with this vein sandwiched between the two. And here you can see, as we withdraw the velocity of blood flow from the pulmonary veins and into the obstructed area, the vertical vein, we see red going to orange, high velocity, and this is definitely substantially obstructed. Now, it's interesting to look at the hemodynamics of this condition, because this is a condition that has undulating obstruction. And often these patients are missed in the nursery initially, because they are misdiagnosed as pulmonary hypertension and manipulations are done. And then what happens is, as the obstruction gets severe, the cardiac output falls. When the cardiac output falls, the pulmonary pressure falls. When the pulmonary pressure falls, the vein becomes less stiff and doesn't squeeze up against the bronchus so much, and the patient gets better, and then the cycle gets repeated. So the process in the nursery, in the intensive care unit, is one of an undulating course of improvement and non-improvement. And it's obviously important at this stage that whenever you suspect this, to obtain an echocardiogram. Now, not all pulmonary veins of the type 1 drain into a vertical vein. And the venous drainage is quite variable. And so here is the Azygos vein over here, draining into the superior vena cava. And some patients will have drainage not into a vertical vein, but into an azygos vein. And here is such an example in black and white imaging. And you can see that there's obstruction as the azygos vein drains into the superior vena cava here. And another example of the same over there in mag view, showing the obstruction that occurs. And this is an important observation. Here are the pulmonary veins before they drain up. and the pulmonary artery below, superior and inferior vena cava, and right atrial appendage. Now, the importance of this condition is that this issue is being found by Dr. Bruno Marino in Italy to occur commonly when there is right isomerism. So when you look at this, you should look to see that you're dealing with normally related atria, and here is a normal right atrium here. This patient does not have right atrial isomerism, but in the 7 patients that he saw with this condition, 3 of them had right isomerism. So that's an important caveat to identify. Here is an example of one with a splenia or right isomerism, and here you can see the veins. They drain up into this azygos vein and then into the superior vena cava. And this is the sign which was described by Dr. Helen Taussig, the Taussig sign, because the pulmonary veins anchor the heart into the mediastinum. And when the pulmonary veins do not drain, the heart is very floppy and mobile. And here you can see such an example. This is right pulmonary artery over here. Another variant of this condition is one found frequently with left heart obstruction. Professor Anderson has mentioned this. This is a diagram of his from Diane Spicer, actually, showing the so-called levoatrial cardinal vein in association with the hyperplastic left heart complex. And here you see the vertical vein usually coming off the origin of the left pulmonary artery. This is entirely a misnomer because this is not the cardinal vein. We've recently reported the presence of a left superior vena cava with levoatrial cardinal vein. So its embryology is somewhat not determined, but it's a misnomer to call it a levoatrial cardinal vein. And a left vertical vein is probably better. And here is an example from a patient of mine who lived until the age of 12 with a hypoplastic left heart syndrome. And you can see this tiny aorta, and she had a patent ductus which didn't close. And here you see the vertical veins coming off the origin of the left, draining up into this vertical vein, and then into the brachiocephalic vein, and then from the superior vena cava into the right atrium. And here is such an example. And you can see the vertical vein here behind the pulmonary artery. Mild obstruction led to its pulmonary hypertension, which remained, and that eventually caused her to demise. And here you can see the large vertical vein, different from the superior vena cava, because the flow is going in opposite directions. It's traveling in the ascending direction here. And then when you see the superior vena cava, it's coming back away from the transducer and into the chest. And here are the pulmonary arteries. And here you can see this little sign, which gets a little confusing. There is the small ascending aorta. And I'll take the labels off so that you can see that better. So we've got here the so-called 3-chamber view, which shows superior vena cava, tiny ascending aorta, large pulmonary artery and bifurcation, and the ascending vertical vein here, and the small ascending aorta seen in sagittal plane imaging. And here is a patient that has a left superior vena cava, but also has a levoatrial cardinal vein draining in here. And here is the picture here of this particular example. So here's a patient with cauda atriatum who also has a levoatrial cardinal vein. When there's total obstruction, this vein may persist. And here's the levoatrial cardinal vein. And this is a paper which is described by us in recent literature using 4-dimensional flow. Now, total anomalous venous return directly to the heart is the second type. And the commonest type is the veins that drain to the coronary sinus. And here are the pulmonary veins draining into the origin of the coronary sinus, which then travels through the left atrium, which is small to begin with, but it bulges into the atrium, making the left atrium extremely small. And here is the mitral valve draining into the left ventricle. And here is this enlarged coronary sinus orifice with the vein draining directly into the right atrium, just in the above the tricuspid valve and into the right ventricle. And this is an easy issue to recognize from subcostal coronal imaging. And I have a combination of black and white imaging and a diagram which looks like a large whale. We call this the whale tail sign. And I'll take the labels off so that you can see that. And then I will enlarge it for you and take off the image so that you can see the black and white imaging with the vein in the black and white image. And then you can see the vertical vein over there coming in there. And there's the color signal of the whole whale's tail. Looking from the back of the heart, you will see this, that here's the left atrium and the right atrium. So we're looking from the back forward. And here you can see the pulmonary veins, and they're draining down behind the heart and into the right atrium. And they indent the left atrium so that the left atrium is even smaller than it usually is in this condition. One of the hallmarks of anomalous pulmonary venous return is total anomalous pulmonary venous return, is that the left atrium, which doesn't receive the pulmonary venous component that leads to the development of the atrium, remains small. So there's another whale's tail sign. It wouldn't matter whether you look at it in 2 dimensions from the back or the front. So I put it in the more conventional orientation rather than match it directly with what we're seeing over here. Now, one of the contentious issues is the veins that drain directly to the right atrium. And I was unable to obtain, after looking through many different archives, an example of this condition. And as Professor Anderson has pointed out, that when the veins drain behind the atrium and into the left atrium and into the right atrium, this condition is very often found with isomeric conditions, and I have one that has isomerism, but occasionally they're seen here. And here is such an example of a patient who was diagnosed actually as an atrial septal defect. And the surgeon went in and he found the veins here and simply put the patch over here, draining the veins into the right atrium. And so this patient was labeled as a ostium secundum ASD. But you can clearly see the pulmonary veins are not draining to the left atrium. Let me take the label off for you, and let's show you that again. Here are the pulmonary veins. There, that was pulmonary arteries in blue. The pulmonary veins are seen in red. They drain into the right atrium. And then the difference between an atrial shunt is that if this was the shunt is going from right atrium to left atrium across the oval fossa, across the foramen ovale. So this really are veins that are draining totally to the right atrium and then shunting across. I'm sure that many examples of this condition have been repaired simply when the surgeon opens the atrium and sees the pulmonary veins draining this way, just puts the patch over here, and Bob's your uncle, he takes care of everything. Here's another example showing the shunting going across into the atrial, the left atrium from the right atrium. And let's see what happens from below. There you can see the veins draining to the back of the right atrium. So sagittal imaging is an important complement to coronal imaging. And obviously, in this condition, as in all other conditions, complete echocardiographic analysis is essential to provide this anomaly, to define the anomaly of total anomalous pulmonary venous return. So there are often many other things that need to be taken care of. So I bring you just this cartoon, which was drawn by Diane Spicer for us to show this example and bring it to your attention. Now, veins draining below the heart. Now, as opposed to the fact that most obstructed veins occur from veins draining above the heart because they're 60%, and only a proportion of those are obstructed. Total anomalous pulmonary venous return, which goes below the diaphragm, is by definition an obstructed pulmonary vein. And we'll see that the veins that drain below the heart can obstruct in various positions. Now, when the origin of Doppler color flow became important, it was easy to recognize this condition. Before that, contrast echocardiography was the only way to define this condition, because the veins, the vertical vein, is the only structure on the other side of the pulmonary capillary, and contrast echocardiography, the only thing that is on the other side are the anomalous pulmonary venous return. So I'm not going to go any further into showing you that, but I'll show you the unique features of anomalous pulmonary venous return draining below the diaphragm. Here are the bronchi, which actually, as you look at these bronchi, they look symmetrical. And symmetrical right bronchi usually suggest right isomerism. So there's right isomerism here. You can see the aorta is a right aortic arch here. And here is the characteristic feature of the vertical veins. They generally don't drain to a confluence as many of the other veins drain, but they drain in this so-called inverted Christmas tree or fern appearance into a vertical vein. They then drain into the porta hepatis, and through the porta hepatis, they go either through the ductus venosus or directly through the liver and into the inferior vena cava, usually via the left hepatic vein and the ductus venosus, where it drains, and into the heart. And the easiest way to recognize this is through a subcostal sagittal cut. And here you can see the hallmark feature of the heart. This is front, back, top, and bottom. And here is the right ventricle lying over the heart here. Here is the liver. Here is the spine at the back of the heart. And in front of it is the pulsating descending aorta. But there's a vein, and the vein is carrying blood away from the heart. The blood is going in the same direction as the blood in the descending aorta. And it will lead to this little sausage. And if you give saline contrast, this is the only part of the heart that remains free of contrast, as I was mentioning above. Now, here is another beautiful example of this usual form of venous drainage. Here is the dissection has taken the heart out of the place here, and you can see all of the veins, and you should look for all of these. The fact that bronchi are backwards. Here's the heart on the other side here. So this is from the back frontwards. So this is right side and left side, looking from the back forward. And here comes the vertical vein draining into the porta hepatis before it goes into the heart. And here is an angiocardiogram which was shot in the pulmonary artery. And here you can see the venous confluence draining to the portal confluence and then to the vertical vein and thence up to the heart. Now, one of the interesting ways of doing this is from the suprasternal notch. And when you place the probe in the suprasternal notch, you will image all of these structures. And here, hello? Oh, okay. So here is an example of a suprasternal coronal cut showing the vertical veins as they drain down to this, the pulmonary veins as they drain into the vertical vein and down into the heart. And let's just get the labels off for you and show you the image. So we're seeing black and white and color. And here you can see 1, 2, 3, 4 pulmonary veins. They're not draining to the left atrium, which is seen in front of this, behind the aorta with the pulmonary trunk up front, and draining down into the vertical vein, and then to the porta hepatis, as we see here. So this is a very interesting and easy way to look at total anomalous pulmonary venous return from below, and it should be part of every examination of patients with total anomalous pulmonary venous return, regardless of where they originally come from. And of course, this is an emergency. Here's an example of the CT scan showing this particular pattern of the vertical vein with everything coming in. But I think that most of the time, if you can get imaging that's as good as this, the patient should be sent to surgery without further delay, because the use of contrast accentuates and perpetuates the obstruction that is present within the pulmonary veins and really doesn't do the patient much good. So there you go. Now we will trace these veins for you. Here you can see that there are 1, 2, 3, 4, 5, 6 veins draining behind the heart here. And we're looking at this again from the back. And now we'll take a slice through this in both the sagittal and the coronal cuts. And here you can see the vertical vein draining into the porta hepatis, through into the ductus venosus, and then into the hepatic vein, which drains into the right atrium via the inferior vena cava, the inferior caval vein. Now, the reason to show this, of course, is that the vein has potentially got 3 sites of obstruction. The vein can be obstructed as it comes through the diaphragm over here, and this looks like this vein, the diaphragm has been dissected across here, but it does look like there's a narrowing in this region. So over here is the first site of obstruction. The veins may be obstructed within the porta hepatis. They may be obstructed, we'll get to that, in the portal vein. And of course, the ductus venosus can constrict. And of course, when the ductus venosus constricts, the pulmonary venous pressure has to be dissipated into systemic venous pressure. So the actual liver then becomes the site of obstruction. And when that occurs, as it does sometimes when the patients present late, you will find these huge sinusoids within the liver. So this is a sagittal plane imaging. And here you can see the black and white image, and there's the descending aorta with the pulsations. Here comes the vertical vein down, and you can see some obstruction at this pulmonary venous site over here. Here is the ductus venosus. And then here is the left hepatic vein, which is also constricted as it enters the inferior vena cava. So multiple sites of obstruction. And then this is just a coronal look showing the porta hepatis, the ductus venosus, the left hepatic vein with obstruction here as it enters the inferior cava before it drains into the heart. And of course, when you sample in this region, you already see the signs of obstructed veins without any sign of pulsation. So this is another way of looking at pulmonary veins below the heart. Now, I think one has to be very careful when you look at totally anomalous pulmonary venous return to account for all of the pulmonary veins. And the way to do that is to make sure that you see them. Sometimes there are 5, as I've shown you. sometimes there's 6. So you have to account for them all. And the best thing that you can do is look in other directions to make sure that there are no anomalous veins draining in any other site, because that certainly does complicate the pattern of repair. And here you can see is a vein where, like a Scimitar syndrome, the veins are draining below into an inferior vena cava, like a Scimitar syndrome, and the left veins, so those are the right veins accounted for on the specimen, are draining through the hemodynamic vise into a vertical vein, into the brachiocephalic vein, and then into the superior vena cava. Here's the right ventricle opened, and here's the inferior vena cava. And when these veins drain in this position, they don't go into the liver, they come into the diaphragmatic portion of the inferior vena cava. The diaphragm has been removed, but you can see the liver with the inferior vena cava coming through it. So this is like a scimitar vein, which I'll show you a little later on. And here are vertical veins. And so here you can see the two examples. Here, the vertical vein with the hemodynamic vise in it over here. And here is the vein draining into the supradiaphragmatic portion of the inferior vena cava. And I'll just enlarge that so that you can see that. So the interesting thing about mixed veins is that when you've studied a number of patients with mixed pulmonary veins, you will see all of the types of anomalies that occur with partial anomalous pulmonary venous return. And so you can apply this back to partial anomalous pulmonary venous return, or look at all of your experience with mixed pulmonary veins, and you will see all the different types of partial anomalous pulmonary venous return as well. So here we're focusing on this vertical vein coming down here, and here we see the ascending vein coming up here. So a beautiful example that explains the two features, and obviously you have to do two different cuts to find these veins. So here are the examples of mixed pulmonary veins that you can see. And here are vertical veins draining directly to the right atrium, some veins draining to the right atrium, some to a vertical vein, some below, total with vertical veins in this direction. All the vertical veins above, here veins to the coronary sinus, and so on, and even draining from the heart to the coronary veins. So, you know, there are a variety of veins, but by the time you've looked at total veins, you'll see all of these varieties as well. So this is a very interesting young lady, because this young lady came to us early on, and the mother thought that the daughter was beautiful enough that she didn't want her to have a median sternotomy scar, and so she asked for a submammary incision. And when the submammary incision was done, the atrial septal defect could be recognized, but somehow or other they failed to recognize that there were also anomalous pulmonary veins draining through a vertical vein into this brachiocephalic vein and superior cava. And the patient came to our institution for an echocardiogram, and this is the CT scan, which I'll go over with you in a moment. But let's just show you the hallmark pattern, and this was in part of a complete exam showing a vertical vein draining into a brachiocephalic vein. This is because there's zero flow recognized at 90 degrees here. So here's the superior caval vein and the vertical vein, and here is a left pulmonary vein, lower pulmonary vein draining to the heart here. And let me just go back again and show you this vertical vein, and we'll look at this going round here. You can see most of the veins drain below, but there are also a lot of veins from the upper lobe draining into the superior vena cava. There you see the vertical vein very beautifully. And I think that when there's no urgency, as there is in total anomalous pulmonary venous return in the neonate, that there is time for such beautiful representation. This is a patient who had the Scimitar Syndrome, also had, unfortunately, extralobar sequestration through a vessel coming off the celiac artery, and the surgeon went in and tied off the celiac artery by mistake rather than the anomalous pulmonary artery, and the patient developed hepatic necrosis and died. And so we have this example here from a subcostal view showing the so-called Scimitar Syndrome. And here are all of these veins here draining into the inferior vena cava and then into the heart. So here is the scimitar. And here is an angiographic example, which was given to me by one of my colleagues at Stanford, showing the vein draining into the inferior vena cava in the supracardiac position, supradiaphragmatic position, not supracardiac, supradiaphragmatic position, and into the heart. And here are the echocardiographic examples. Now, what I will point out to you, and I think that this is an important issue for echocardiographers, is that the veins, in order to see veins, you have to lower the scale. And you can see here I've used 23 centimeters per second. That allows you to actually see Doppler color signal when it's low, as the velocity of flow in veins generally is, even when there's obstruction. So there is I think an MRA angiogram showing those veins. And here is the echocardiogram showing the vertical vein in color coming above the diaphragm and into the diaphragmatic portion of the inferior vena cava before it drains into the right atrium. And here are the hepatic veins, as you can see, with some acceleration in the veins as they come into that narrow left hepatic vein. And here is just another example showing in a clearer example of the image the vein flow in this Scimitar Syndrome. The Scimitar Syndrome was described by Dr. Catherine Neal, who was one of my co-fellows in London when I worked with Bob Anderson, and was also a colleague of Helen Tauzik. And she described this as the Scimitar Syndrome. Now, the other thing about the Scimitar Syndrome is that you can see it in long axis as well. And here's another scimitar vein, and here's a parasternal long subcostal, I beg your pardon, sagittal cut. Yeah, not parasternal, subcostal sagittal cut. And here's the whole inferior vena cava draining into the right atrium. And in the normal heart, you'll see the right lower pulmonary vein running on the diaphragmatic surface and then up towards the atrial junction with the superior pulmonary veins. So in the normal heart, you can see that particular pattern. But when there is a Scimitar Syndrome, the venous drainage goes from the pulmonary vein directly into this supradiaphragmatic portion of the inferior vena cava. And there you see very clearly this from this position, and you can even orient this in a different position, an anatomic position, to show the vein coming down in a sagittal position here. This is back and front, top and bottom, and opposite from the one I've shown you previously. And here in 2 dimensions, we have been able to see this vertical vein draining to the supradiaphragmatic portion of the inferior vena cava. Now, just isolated anomalous pulmonary veins, the commonest one are right pulmonary veins. And here is an example, and you have to look at the right side opened up here, right atrial appendage, right atrium, oval fossa, inferior cava, sinus intervenarum, and here the pulmonary veins draining to the origin of the right atrial superior vena cava junction. And here is the azygos vein coming up over here. So it's clearly below this, and here's the rest of the superior vena cava. And here you can see subcostally very easily this particular vein draining here, which is the commonest site for anomalous isolated pulmonary venous anomalies. So there's the labels there, and I think that we've seen many examples of that. And you can see the whole superior vena cava. You can often see the anomalous veins. You'll see the pulmonary artery, which is enlarged because of the left to right shunting that occurs in this condition. Here again are veins that are not draining to the azygos vein. Here's an azygos vein, and here is the right pulmonary artery, and here is an anomalous pulmonary vein draining into the superior vena cava. This is a picture given to me for this particular presentation by Diane Spicer, and here is an isolated anomalous pulmonary vein draining into the superior vena cava. And I think you can see that very clearly. And we have both black and white and superimposed color images and alternative frames so that you can see the morphology and the physiology of the flow as we've superimposed that. This is something that I've done. No machine is capable of doing that. Here is another isolated pulmonary vein, which is another common site, is directly to a vertical vein, just like we see with type 1 veins, but instead of it being all veins, it's just type 1 veins. And the question obviously involves about what you do with this. And obviously these patients may not need surgery in the neonate, as this is an example of, but what happens with life is that the pressure drop between the systemic vein and the pulmonary vein is greater than the pressure drop in the other pulmonary artery to pulmonary vein anomalies. And there is certainly an increase in the velocity through life that occurs, and this may actually get larger and larger and necessitate surgical closure later on in life. But these patients definitely need to be followed. Here's another example of a drainage to the SCV-RA junction. And you can see here pulmonary veins on this side draining to the left atrium. Here's fossa ovalis, and here is the anomalous vein draining in this direction in a parasternal short axis cut. So I can show you numerous examples of that. There's the azygos vein, and you see the veins draining into the azygos vein before it drains into the superior vena cava. Now, veins may drain to the coronary sinus, and when they drain to the coronary sinus gets large, and when the coronary sinus gets large and you see this, you may believe that you're dealing with an unroofed coronary sinus, a so-called coronary sinus septal defect. And here you can see the right pulmonary veins here with the probe in the right pulmonary artery draining in through the coronary sinus into the right pulmonary artery. And so this large coronary sinus can fool you that you're dealing with a coronary sinus septal defect. And if the surgeon then goes and closes off the coronary sinus septal defect, he gets obstruction in the pulmonary veins. And this is indeed what happened in this patient that I'm showing you. We did not make this diagnosis of partial anomalous return to the right pulmonary veins to the coronary sinus. And the patient went to surgery, and this was closed off as a coronary sinus septal defect. And the patient didn't do very well off bypass. And this was discovered. And we then went back and corrected this anomaly. And here is what happened at surgery. You can see the right pulmonary veins enlarged and looked almost like there was quadratriatum. These are microbubbles that are related to cardiopulmonary bypass. And you can see that they're situated only in the right pulmonary veins. The left pulmonary veins were normally drained. So I can show you even the fact late that they still occurred, and that we were able to go back and correct this anomaly. And I think that if we can show you mistakes, maybe you will be able to see that it's not all black and white and easy to do. And here is the report of this in clinical cardiology, showing people that had done cardiac catheterization on these patients and had recognized this anomaly. And here is such a cartoon of this issue, together with the reference of this condition. So it's not that it hasn't been described, it has been well described in the literature. So that's all I have to say. I finished on time despite my poor start, and I'm going to unshare my screen and try and answer questions that you might have on this.
Thank you very much, Dr. Silverman. It was a great, great presentation. And for sure, we learned a lot. There's no questions on the Q&A chat box. So guys, please don't be shy. If you have any question for Dr. Silverman, please type on the Q&A chat box, and we are going to be happy to answer. There's one question now from Seving. He's asking you, he uses the word cuts, but I think he means the projections on the echo that you recommend in an urgent situation.
I'm sorry, just say that again, Grace.
He wants to know which images are you going to use when you have an emergency, when you have a very sick neonate, yes, and what would be the easiest one to rule out or to make the diagnosis?
Well, I would do. I would start off subcostal, and I would look for the sick babies. I would look for a subcostal, coronal, and sagittal cut immediately. If I find a vertical vein going below the diaphragm, that's enough to get the patient ready for surgery. And Dr. Marshall Jacobs has reported 2 patients where they made this diagnosis in fetal life, and they took the baby straight from the delivery room to the operating room without going to the intensive care unit, because these patients can be very sick and they can die. And I think that brings up another important point that we could offer, and that's that in our experience, this condition is the most frequently missed condition in fetal echocardiography. And so if you're missing this condition, these patients are going to become sick, and morbidity is increased. And I think we need to look very carefully at veins in the fetus, and hopefully that will prevent some of the long-term problem of these patients from the postnatal surgical procedure. So I think to answer the question, again, I would go subcostal, coronal, and sagittal views, and then I would go suprasternal and look, or transmanubrial, and look to see if I could find a vertical vein anywhere. So that's what I would do. Also, I'm not, most of these patients, when you get to see them, they've already had some form of resuscitation. So they have a venous line in, and I think that the use of saline contrast is very important, because once you find a right or left atrial shunt, you know that you're either dealing with the obstruction of the right heart, you're dealing with pulmonary hypertension, or you're dealing with totally anomalous pulmonary venous return. So once you find that, you know that your problem is in those three categories. If, of course, there's no right to left shunt at atrial level, it's highly unlikely that you're dealing with anomalous pulmonary venous return that's going to be obstructed. And let's make a point, very important point, is that the only veins that are a surgical emergency in the total anomalous and partial anomalous venous return are patients where there is obstruction, okay, either type 1 or type 3. It's very rare to find obstruction in type 2 veins draining to the heart directly. So those are the veins that we have a problem. Sasha, you wanted to say something?
Yes. First of all, I would like to thank people from Libya. Yes, Dr. Mariam, Dr. Naema, and Dr. Mohammed that I know very well and now are in connection with us. But I have a big question for you, because generally after surgery, one of the main points is pulmonary vein stenosis.
Yeah.
This is something that is a very difficult point, and I saw that there is some question also in the Q&A. I think that we are now in the best position from you to understand how and in which way we have to make it on echo, and which type of message to share with the staff.
Yeah, I know. Look, I understand the problem. You know, I think that a number of the problems that relate to the veins are intrinsic to the disease. And you may see it or you may not see it prenatally or preoperatively. I mean, the problems occur as we're talking about venitis. And that problem is probably not related to surgical treatment. And that particular subgroup of patients is so difficult to handle. There's a very high morbidity and mortality in that condition. And I don't think there's anything that we have done that will recognize that on a pre-operative basis. The veins themselves can be very abnormal and small. And of course, the velocity is high. And we don't know what this increased velocity is doing in terms of establishing a abnormal biology of what happens in the pulmonary veins. And I would say that that's really the issue. I see a question from my friend Dennis Wood over here. Dennis, yes. Good morning. I think that veins to the coronary sinus, I see from the picture that I showed you that it looks like coronary atrium, but yes, I think that there is a differential for that, but I think that it's easily definable as veins to the coronary sinus from coronary atrium. You usually with the coronary atrium, there's a place where the veins are draining into the left atrium, and may be associated with an atrial septal defect. But I think overall, one can make this differential. Now, an anonymous attendee asked me about the preoperative. That's your question, Sasha. I wish I had a crystal ball. We aren't very good at predicting what's going to happen in the future. I think when you have a small pulmonary vein with a really difficult area to do anastomosis, that is a problem. And I've seen patients that have surgical obstruction, and that can be, I think, taken care of with a sutureless kind of technique, you know, because you can get a better anastomosis with the sutures being placed not in the pulmonary veins, but in the pericardium. So that's fine.
Yes. There is a question that I think that is a part of your story. Miguel Arizapana is asking the famous story about the small left ventricle with mitral annulus and small non-hypoplastic long axis with total anomalous pulmonary drainage. Are there any consideration to decide whether to correct the drainage or the viability of the left ventricle? Please, Norman, this is your
well,
this is your.
No, I haven't pulled it up, but we wrote a paper, Dr. Colin Poon and I, which has been well published in the Journal of American College of Cardiology, where we actually looked at what was a hypoplastic ventricle. And what we found was that if you took a totally anomalous pulmonary venous returns and you calculated the volume of their ventricle by two-dimensional echocardiography, the ventricles were always small. They were tiny, in fact. And the septum bulged back from the right ventricle into the left ventricle, making the left ventricle more like a semilunar structure in cross-section, a complex scaphoid appearance. And we made a calculation about repair of total anomalous pulmonary venous return. And we found that if we just bulged the septum in the opposite direction as it is after birth, after operation, that we got a much increased volume, and that this correlated reasonably well with the calculated volumes that we got after birth, expected volumes. And I think that this, one of the important issues here, I think this is a very important issue, is that we have to stop thinking of the ventricle as a solid structure. It's a dynamic structure. Even the annulus of the valve is dynamic. You can increase this annulus size as well as the chamber size by just changing the volume. And I can tell you from my post-operative, intraoperative echocardiography on this patient, that as you come off bypass, the left and right side of the hearts change. The left heart, it looks almost normal. Okay, and the reason is that you're filling it up with a preload and a pressure load and an afterload, and the ventricular septum assumes its position. So I don't think I would ever worry about a very small left ventricle in total anomalous pulmonary venous return. I would think that the best hope for the patient would be that, and I would think that most of them will not be hypoplastic left heart syndrome. Of course, there are patients that have hypoplastic left heart syndrome with small aorta and total anomalous pulmonary venous return, and that's a whole different kettle of fish. But I think that generally, if you think of the left ventricle in total anomalous pulmonary venous return, it is hypoplastic in the sense that its volume is diminished because its loading conditions are so altered. And that when you fix the loading conditions, the ventricle looks exactly normal, and it looks normal as you come off bypass. It's quite an amazing thing to see. And I'm sure you're smiling, Sasha, because you see this from the outside, right? Yeah. You don't need an echocardiogram to see that.
Yeah, I would like to say that you changed the story of this disease, because that paper and that message arrived directly to each surgical theater of the world. Because for a long time, and probably you are more experienced of most of the people, anomalous pulmonary venous connection was sometime identified with hypoplastic left heart syndrome.
Correct.
And you this paper changed the story of the surgical.
Well, I'm happy for that. And Dr. Tom Graham is actually the reviewer and wrote an editorial on this. But I think that we have to stop thinking of ventricles and great vessels as being adynamic structures, plastic, like a model, a 3D model, printed model. They aren't 3D printed models. They're dynamic. And I think you see this also in coarctation of the aorta, where the isthmus is sometimes hyperplastic. And you fix the coarctation, and the isthmus blows out and it looks normal. So I think that lots of parts of the heart are dynamic. You see this in anomalous coronary arteries, for example. in an anomalous coronary artery, the right coronary artery is almost always enlarged. And when you take the anomalous coronary artery off the pulmonary artery and you reimplant it, immediately you come off bypass, the right coronary artery becomes small and the left coronary artery increases in size. So we know that this is an important feature about generally in terms of cardiac disease.
There is a question that Ali wants to ask to you, and he told me that if you make some comments about total anomalous and multiple small draining veins, if you have experience with small draining veins again.
You know, I don't have experience along that line. I think that we've had patients where, you know, for example, there is pulmonary vein stenosis and it doesn't drain, and you can't, that they're small pulmonary veins, and those patients all die, unfortunately.
So the point is, the question, one of the last point is about cor triatriatum. How it is difficult to differentiate total anomalous in the coronary sinus from cor triatriatum?
Well, I've never really had a problem. You know, the only veins, the line that was originally described was really the coronary sinus. The cor triatriatum is, you'd have to look to see where the atrial appendage is, and the membrane of a cor triatriatum is almost always the ghost between the pulmonary veins and the atrial appendage, and it runs in a more different direction. I must say I've never really had the problem, so it becomes really difficult for me to look at it. But in the patients that I've seen with cor triatriatum, the blood flow will get from the cor triatriatum into the left atrium by some way. And in cor triatriatum, one of the things that happens that I think is, and I'm just talking from my own experience now, which goes back over 40 years of echocardiography, is that the membrane in cor triatriatum, that obstructed membrane, is often thickened and abnormal and has cartilage in it, and it is very highly echo-reflective. And then the pressure forces it into the funnel of the mitral valve. So it becomes sometimes difficult to recognize a supravalvular mitral ring from cor triatriatum because of the fact that as the pressure enlarges, it pushes it in there. But cor triatriatum will always have a little perforation somewhere where the vein will go back into the left side of the heart, even if it drains through an atrial communication and then back through the bottom of the atrial communication back to the left side. I wish I could give you an easier answer, but those are the only things that I can think of. I've never personally had that problem in 40 years. Okay, let's see. Is there anything else here?
Yeah, there is one. Okay, this is some from for echocardiographies. How do we distinguish the azygos vein from the anomalous pulmonary vein in partial pulmonary venous retard or right pulmonary vein to superior vena cava? So it means if there is some anomalous return in superior vena cava.
Yeah, well, I mean, the azygos vein usually does to the right mediastinum what the aorta does to the left mediastinum, and that is it goes over the bronchovascular bundle on the right side. So the azygos vein will run higher up. I mean, I think it's a problem in, for example, in sinus venosus ASD, where you have anomalous pulmonary veins draining to the superior cava, is that you have to look for where the azygos vein is draining above the right pulmonary artery and bronchus. So you'll see that white area, and that will mark where the veins are, because veins will not drain anomalously beyond the azygos vein. I think that if there becomes a problem with this condition, it's not a surgical emergency. And I think that in any case with beyond a surgical emergency, the tendency now is to consider perhaps other additional imaging modalities. And I certainly have been so impressed with the ability of CT to actually define these anomalies in three-dimensional space for us, that I would have no hesitation in going to another technique to establish this a absolutely precise image for the surgeons.
So we go with the last question, and we will thank all of you. The question is from Miguel again. The question is about vertical vein or collector. So they say if you have experience about the absence of collector or a tiny collector or the obstruction of the collector.
I have very little experience. Of course, those patients where you can't find the veins, I mean, that may have to go for catheterization or CT scan. And those patients have done poorly. They've almost all died.
Yes.
I mean, there's some, those are conditions we cannot save.
Okay. So thank you, Norman. If you want to say something for the people, because if you saw, we have people from Armenia, Libya, Iran, Jordan, Argentina, Ukraine.
Yeah. So
Dubai.
My sweater is made in Jordan this morning. The sweater I'm wearing was made in Jordan. So I feel akin to all of these.
From Jerusalem, from Peru, Miguel. So
yeah.
Amazing session, guys. Really amazing session.
Thank you, Grace. Lovely to see you today. Thank you for participating. I must give you a little confession. I had actually prepared today 2 talks, and I was thinking I was going to give congenitally corrected transposition this morning. And so I've been working on congenitally corrected transposition. When you said total veins, I had to go back and look on my computer for it. I had no rehearsal. This is absolutely blank without any rehearsal.
So Grace, what is the next appointment?
So next month is going to be tetralogy of Fallot, Dr. Silverman. Prepare the right one.
All right. Okay. So I'll get the tetralogy of Fallot lecture ready.
Thank you very much. We welcome all of you. Thanks, Norman. Please.
Okay. Thank you, Sasha and Grace. Goodbye, everybody. Thank you.